Okay.
Yes,
Okay,
I did. Yeah,
Okay.
that's done.
Thank you.
Yeah.
Okay, Camille.
All right, thank you so much. Can you all hear me okay?
Yes.
Okay, great. Hi everyone, and thank you Lions Soul Association for inviting me to present at this year's Catch Leadership Training. My name is Camille Mendaros, and I am the program manager for a tobacco control network called Aspire, which is implemented by APPEAL, which is stands for Asian Pacific Partners for Empowerment, Advocacy, and Leadership. We are based in Oakland, California. And today during my presentation, I will give a brief overview of tobacco use in Asian American, Native Hawaiians, and Pacific Islander communities, or I'll refer to them as AA and HPI because it's pretty long, as well as give you examples of tobacco control policies that APPEAL have been advocating for to advance health equity in AA and HPIs, AA and HPI tobacco control. Next slide, please. All right, so here are the objectives for today's presentation. We want to increase understanding of tobacco issues impacting the diverse AA and HPI communities. We want to recognize the need for disaggregated data among AA and HPI subgroups, and then identify tobacco prevention policies to help achieve health equity in tobacco control. Next slide, please. All right. So this chart, this is a chart that shows the leading preventable causes of death in the US. Although this data is a little old, it still remains very relevant today. Tobacco is still the #1 cause of preventable deaths in the US, more than any of these other causes of deaths listed, causes of preventable death listed, put together. There's alcohol consumption, motor vehicle deaths, firearms, sexual behavior, and illicit drugs. So if you combine those deaths all together, there's still a lot more tobacco deaths compared to those preventable causes. So, you know, smoking causes cancer, heart disease, stroke, lung diseases, diabetes, and COPD, to name a few. And on average, smokers live 10 years less than those who don't smoke. Next slide, please. So why is commercial tobacco still a problem? Here are some more alarming tobacco and disease data. 20% of cardiovascular disease deaths in the US are due to smoking. And smoking increases your risk for coronary heart disease by 25 to 30%. And in the US, 80 to 90% of lung cancer deaths are actually linked to smoking, which is really high. Next slide, please. Okay, great. So you'll often hear of tobacco control organizations refer to tobacco use as commercial tobacco use and not just tobacco use in general. And this is because we do recognize that for Indigenous people and American Indians, tobacco is a very sacred plant, and traditional tobacco is actually used for medicinal purposes, and they're used for offerings and gifts to people who they love and respect. So when colonization happened and Black people were stolen from their own lands for slavery, their bodies were used to farm tobacco for commercial purposes because Europeans saw tobacco as a highly profitable crop. And unfortunately, as the demand for tobacco increased, so did, when it was first commercialized about early 1600s, so did the demand for slaves. So there's a history there between tobacco, colonization, and slavery. And I just wanted to give you a background on why we refer to tobacco use as commercial tobacco use compared to just traditional tobacco. Next slide, please. All right, so fast forward centuries later, and the tobacco industry is still causing big problems and have targeted priority populations and people of color to market their products. In one of the tobacco industry documents, which can be found online on the UCSF website, the tobacco industry described Asians and Pacific Islander market important due to population growth and geographic clustering, meaning Asian and Pacific Islander communities tend to live in the same areas or regions, which makes it easier for the tobacco industry to target the communities. Next slide, please. And then a tobacco industry was also quoted calling Asians and Pacific Islander communities a potential gold mine because people who are Asians and Pacific Islanders are predisposed, quote unquote, predisposed to smoking, initiating that all people who identify as Asians and Pacific Islanders are exactly alike when it comes to getting easily hooked on their deadly products. And this graphic, I found this, I got this from the Tobacco Free California website that depicts that statement that you know, Asians are predisposed to smoking because we are all alike. So it's a powerful graphic right there. Next slide, please. All right. So today, there's still a high prevalence of commercial tobacco use in our Asian American, Native Hawaiian, and Pacific Islander communities. And I'll show you some data in a little bit later in my presentation. And although there have been a lot of successes in tobacco control in the past, at Appeal, we recognize that there are still disparities and inequities in tobacco control that continues particularly in priority populations. So our work is really dedicated to eliminating these tobacco health disparities in our communities through community-led events, leadership developments, but our main focus is to really advocate for tobacco control policies that benefit AA and HPI communities. Next slide, please. Okay, so when we talk about policy change, which is really the center focus when we talk about tobacco control, there's another level of complexity that needs to be taken into consideration. Ultimately, we are working towards a social norm change and not just policy change. So because we are looking at it that way, it's not just legislative policy change that we are focusing on, but we look at community level within leadership. We look at mainstream institution policy in both private and public institutions, and changes that can be made at the corporate level, whether that's impacting the tobacco industry, the e-cigarette business, or businesses at the local level. That's why Appeal looks at policy change at these 4 different levels, or prongs as we call it. First one is community level, where tobacco is not always a high priority at the community level. And then we have mainstream institutional level, where priority populations have not been the priority. And then there's the legislative level, where neither priority populations or tobacco are the priorities. And then you take a look at corporate policy, such as the tobacco industry or food industry, where priority populations have been the priority and the target. It's usually very hard to navigate corporate level policies. So at Appeal, we tend to mainly focus on those 3 levels: community policy, mainstream, institution, and legislative. One good example of community policy is not to accept any tobacco industry money to fund local festivals and community events, and make local community events smoke-free. So that's one good example of community policy, because you work with local community organizers to make that happen. And although community policy usually is not as sustainable as legislative policy, it's very important because community policy is where you get community leaders involved in tobacco control that we are doing. Next slide, please. So because of the uniqueness of different communities and the fact that communities are at different levels of readiness to do tobacco control, much less to do tobacco control policy work, Appeal came up with this visual that could help communities see their journey through policy change. In communities where readiness is at the earliest stage, it's very important to take into account that there's a very long process of assessment and capacity building phases. So this assessment phase can include understanding what the landscape is and what has been done in the past. And it's also very important to recognize that for some communities, historically, they have faced different traumas that make it difficult for them to engage in policy change, such as, for example, for immigrant communities who come from places where the government itself is a barrier, and you're not supposed to talk about politics at all and policies. For them, engaging in policy change can be very traumatic. So you need to take that into account during the assessment process. The capacity building phase is also very important in that you should recognize that not all communities have engaged in tobacco control for years. We have to build expertise around policy skills, and you have to build leadership in the community to do the tobacco control work as well. So this diagram you're looking at, which we call the river journey, takes into account, cultural elements and barriers. And for some communities, they might already be in that bridge that you see, and they're ready to take on policy change. But the reality is a lot of our communities are still in that assessment level, the very beginning of their journey towards tobacco control policy change. Next slide, please. Thank you. So here are just a few examples of AA and HPI focused policy recommendations to help advance health equity in tobacco control. So at the legislative level, we want to establish menthol and flavor restrictions and bans in cities where there's a large AA and HPI populations. Oakland, California is an example where they recently there's a large number of Asian population in Oakland, and I think a couple of months ago they were successful in passing a flavor and menthol ban ordinance in Oakland, California. So congratulations to Oakland. And then we also want to advocate for AA and HPI legislators not to receive any monies from the tobacco and e-cigarette companies. And for mainstream level, we want to fund and conduct surveillance studies to monitor tobacco use for NHPIs as well as AA Asian American subgroups, particularly in state health departments. And we also want the mandating of accurate representation of desegregated AA and HPA data, whether that data is in educational materials, fact sheets, websites, and commercial tobacco control organizations. And I'm just gonna talk a little bit about data segregation and tobacco control at Appeal, because we've been advocating that for so many years. Next slide, please. Okay, great. So on this slide, you see the breakdown of AA and HPA, AA and HPI population within the US. As you can see, a large portion of Asian American population are of Chinese descent, and that could be due to the fact that they were among the very first Asian groups to migrate to the US. Similarly, Native Hawaiians are the largest Pacific Islander population, and could be because Hawaii is a state and have been migrating between the continental US and Hawaii since the early 1900s. So the focus on AA and HPIs is very important because of the vast amount of people that are not typically present in topics such as health and tobacco control. Many times in data collection, particularly in mainstream institutions, the AA and HPI populations is combined together into one data. Therefore, the needs of distinct populations are not properly met. The focus of AA and HPI populations is also important because it is made up of very diverse subgroups, as you can see at this chart. This is not even all the Asian American Native Hawaiian and Pacific Islander subgroups, and you can see it's very diverse. And Asian Americans are, they're also the fastest growing population in the United States. Between 2000 and 2015, the Asian population actually grew 72% from around 12 million to 20 million. which is the fastest rate of any major racial and ethnic groups. And by comparison, the population of the second fastest growing group, which is Hispanics, Hispanic population grew by 60% during the same time period. Next slide, please. Thank you. So here's the data from 2013, 2014 population assessment of tobacco and health. You can see the maroon represents all the red. I know it's a little hard to see, but I think y'all will have access to this slide, so feel free to look later. But the maroon represents all populations. Men are in red and women are pink. And as you can see, the data is desegregated and we are able to identify the differences in use by subgroup. The findings show that among Asian American groups, current cigarette use is highest among Korean men and lowest among Asian Indian women. So data like this are actually very important in our work on tobacco control because they really serve as proof that our population you have high rates of tobacco use and that we do need resources to address this problem. And when you clump AA and HPI data into one data, it masks these higher numbers of tobacco use among the subgroups. Next slide, please. Okay, and here is the tobacco use for Native Hawaiians and Pacific Islanders. Again, the three leading causes of death for NHPIs are cancer, heart disease, and stroke, which are all linked to smoking. Here we have data from 2014 National Health Survey. The survey found that nationally, about 17% of US adult population were current smokers. And after desegregating that data, you can see there that there are some differences between Native Hawaiian, Samoan, Chamorro, but there's a chunk on that data there labeled as other Pacific Islander. So if you could break that down even more, I'm sure that we'll see more different rates in smoking. Next slide, please. So this is another great example of what data desegregation can show. For Native Hawaiians and Pacific Islanders, not only are they lumped with the Asian category, but oftentimes they are completely left off entirely when we talk about data in health and health disparities. A few years ago, the National Tobacco Use Survey released a report. I think this was from 2017. They released their report on youth commercial tobacco use, and it actually separated Asians from Native Hawaiians and Pacific Islanders. And it showed that amongst all the racial ethnic groups of teens who used tobacco and e-cigarettes, Native Hawaiians and Pacific Islanders actually had the highest rates of tobacco use compared to other ethnic groups. From what, if I remember correctly, I think it was around almost 24%, which is really, really high. 24% of Native Hawaiian and Native Hawaiian and Pacific Islander used smoked cigarettes, which is really high. So again, this will not show up if the data wasn't segregated and you're not able to see the impact of one particular population if you just clump data into one category. Next slide, please. All right, great. Here are some more examples of effective policies that can help reduce tobacco use for both adults and youth. Raising tobacco taxes and prices in general reduces commercial tobacco use. I think as of July 2020, the average state tax for tobacco is $1.82 per pack, but rates really vary from each state. In Missouri, it's like 17 cents, which is like really low compared to New York, which is $4.35. And DC actually has it at $4.50 per pack. So those are really high taxes, and that it reduces tobacco use in general if you raise taxes for tobacco. And then we also want to reduce access to tobacco. An example of this is, Tobacco 21 law, and another good example at the local community. It's actually something that's being done right now by one of our appeal partners. in Central Valley, California. They are working on banning the sale of tobacco and flavored tobacco within, I believe it's 1,000 or 1,500 feet from youth-sensitive spaces such as schools and public parks. So this is a great policy to reduce access to tobacco for youth. You don't want them selling tobacco, like 1,000 feet from schools. That's just a really bad policy. And then the third one is more for reducing secondhand smoke and aerosol exposure. So an example would be a comprehensive local smoke-free ordinances where tobacco and cigarette use should not be permitted in public or shared spaces. Smoke-free policies in multi-unit housings is also a good example to reduce secondhand smoke exposure. A lot of AA and HPI communities live in multi-unit housing buildings, so smoke-free policies in multi-unit housing are very important. Next slide, please. Great. And then I just want to briefly talk about areca nut. In many Asian and Pacific Island countries, cigarettes aren't the only way to consume tobacco. Areca nut is consumed as a tobacco chew and the form of betel nut. Other names of the product include pan, gutka, and buai. And I'm not sure if I'm saying that correctly. And areca or betel nut is popular across Asia and Pacific Islander, and it's commonly used by migrant populations. Areca nut is classified as a group 1 carcinogen for humans. And when it's consumed with tobacco, regular chewers have an increased risk of developing a range of diseases, including oral and esophageal cancer. And the US is actually one of the major destinations for these products, where it's widely available in Asian groceries, and it would be next to common household items such as flour. So I just wanted to acknowledge that cigarettes is not the only tobacco product that is used in our communities. Next slide, please. And I also wanted to briefly talk about just COVID. I'm not a COVID expert by any means, but I wanted to talk briefly about COVID as it relates to tobacco use. There have been more and more studies recently linking tobacco use as a risk factor for COVID-19. And COVID-19, as you may know, is a respiratory disease. And as we all know, tobacco use can impair lung function, where it makes it difficult for the body to fight off diseases. So tobacco users have a high risk of being infected with a virus through the mouth while smoking cigarettes or using other tobacco products. AA and HPIs are at a high risk of getting affected with COVID. There was a study that came out of LA recently, about a couple of months ago, indicating that Native Hawaiians and Pacific Islanders actually have the highest rates of COVID-19 deaths in LA County. Again, if you didn't disaggregate the data between Asians and Pacific Islanders, you would have not seen that number. So a lot of our community members are actually also essential workers, and a lot of AA and HPI live in multi-generational housing. So those are another couple of reasons why we are at a high risk. If you live in multi-generational housing, one family gets infected, so there's like a high risk that you can get your parents and grandparents infected as well because they live in the same house. Next slide, please. And then COVID-19 brings me to the last section of my presentation, which is actually quitting tobacco. And I know right now it's a very stressful time with COVID-19, but I personally think that COVID-19 should give people more of a reason to quit smoking. Next slide, please. So there, are medications readily available right now, both over the counter and prescribed medicine to help people quit smoking. Next slide, please. And then there's also coaching, and we recognize that for our communities, AA and HPI, there's a need for culturally relevant smoking cessation tools to help them quit. So Asian Smokers Quit Line is a free smoking cessation service that provides in-language coaching services in language Chinese, Korean, and Vietnamese. So smokers who want to access their services, they work with coaches to help them through their journey, and also provide some free nicotine patches when they start their journey to quit smoking. And you can find all sorts of resources on their website at asiansmokersquitline.org. So make sure to check them out. They're really great resources. Next slide, please. And of course, when quitting, it's really important to have the support of your friends and family. And like I mentioned, we are at an unprecedented time when we are spending more and more time with our families and loved ones. And for smokers, I think this is a perfect time for them to quit smoking, because you are with your loved ones, right? And when you're smoking at this point, I think there's a higher risk of you exposing your family members to secondhand smoke. So I believe that this COVID-19 is a perfect time for smokers to start their journey towards a tobacco-free life. Next slide, please. Yeah, I believe that's it for me. Again, thank you so much for inviting me to present at your catch training for this year. You can find me at, there's my email there if you have any questions later on after this catch training. Thank you so much.
Thank you, Camille. I just want to point out that Aspire. I think she's trying to.
Uh-oh, did I do that right? Wait a minute, where's the bottom? Okay, I can say this is near to me. Okay. Share. Did it come up? Uh-oh. Wait a minute, where'd it go? Sorry.
At your desktop.
Okay, there, and then slideshow, right?
Yes.
From the beginning. Ah, yay. Okay.
There we go. All right. Take it away.
Okay. All righty. Well, thank you so much. I feel so honored to be invited to speak to this group. I have a very soft spot in my heart for Light and Salt. I think they do an excellent job. You know, I was a co-founder of something called the Asian American Health Coalition Hope Clinic, and it's kind of, Light and Salt was kind of one of the offshoot organizations for us, and so I think it's just kind of it's kind of like your child is you know, grown up and it's doing great. So I'm just so proud of all the things that they're doing. Anyway, I want to give you just kind of a brief snapshot about Asian American and Native Hawaiian Pacific Islander cancer prevention in Texas. Let me see if I can get myself just, there you go. Okay, wait a minute. Okay, I wanted to be able to, okay. So anyway, I think one of the things that is just the elephant in the room is that for right now, because of COVID-19, cancer is taking a backseat to it. And I don't know if y'all remember Saturday Night Live and the character called Toonsis, the cat, in driving a car. This is what this is supposed to be. Is, you know, Toonsis is in charge, like COVID-19, and overrides everything. And even though cancer is important, it's hard to concentrate on it with something so overwhelming as COVID-19. But I did want to share with you that things still continue in the way of comprehensive cancer control in Texas. These were some resources actually shared with me by my colleague, Lynn Nguyen, who's at MD Anderson. She thought these were important things to make sure that everybody on this catch training knew about, that there is a Texas Comprehensive Cancer Control Program, there is the Cancer Alliance of Texas, and there is a Texas Cancer Plan. Okay, another resource for Texas is the Texas Cancer Registry. And this has actually had pretty good data for us to draw upon to look at the profile of NHPI cancer incidence and mortality in Texas. We had a real good friend there, an epidemiologist named Dr. David Rister. Unfortunately, he retired and then passed away too, but he was a real good source and understood the importance of disaggregated data. And I know when I was at MD Anderson, he was very, you know, if you asked him to give you the disaggregated data, he would give you what they had, but he also realized the limitations of the data. But that's still there, and we're trying to have new alliances with that group for getting data when we request it. So the Texas Cancer Plan, the last version was in 2018, and I kind of want to go over it briefly. There are 5 goals related to primary prevention and risk reduction, and they have to do with kind of what Camille was saying earlier: eliminating tobacco use, adoption of healthy behaviors like good nutrition and physical activity, and avoiding or preventing obesity, skin protection behaviors to reduce new cases and deaths from melanoma, reduce the risk of cancers related to environmental carcinogens, and increase vaccination rates for vaccines shown to reduce the risk of cancer. And in a way, we can kind of relate a little bit this to COVID. You know, as Camille said, tobacco use increases probably respiratory disease and increase the risk for COVID. Similarly, healthy diet and regular physical activity will improve your immunity to protect you from any viruses. We are asked to wear masks and practice social distancing. You can see those as environmental exposures. And finally, until a safe and effective vaccine for COVID is found, herd immunity is probably not going to be possible. Under screening and early detection, I'm sure it's the same way wherever you are. Many people are avoiding early detection and screening. Here in Houston, one of our major cancer screening places is MD Anderson Cancer Center, although we have other hospitals that provide this screening. But because of the fear of COVID, unfortunately, I think we're seeing some decreases in people going in for cancer screening, that they're afraid they might contract the virus, and so they're avoiding screening. But I know for sure that Anderson is providing it in a safe way and taking all the precautions necessary to allow for people to still come in for all the regular screenings that they should be having. Goal 12 is to increase timely access to quality cancer diagnostic treatment and palliation services. Similarly, unfortunately, a lot of our, like Camille said, low-income AA community members live in multi-generation households, which increases the possibility of disease spread, including COVID. And also it makes it harder for people who are trying to seek treatment, who might be immunocompromised, to stay healthy and well. It's very, very difficult for many of our communities. And then quality of life and survivorship is goal 13, promote overall health and well-being of people affected by cancer. For cancer as well as COVID, it is difficult to improve quality of life and survivorship when social determinants of health need to be addressed first. And the 14th goal is strengthen the public health and clinical healthcare systems infrastructure by supporting the delivery of the most appropriate evidence-based cancer prevention interventions and clinical care services. I think, as AAPIs, AHNHPIs, we're still learning a lot about what are the evidence-based cancer prevention interventions and clinical care services. And I'm proud to say that, when I was at Anderson, as well as, the Hope Clinic continues to try to develop culturally and linguistically appropriate programs that are relevant to our community. And I'll talk a little bit about those a little bit later. One of the stories from the ground I heard is that, my last job was actually with the Houston Health Department, and they were very happy. They said, oh, Beverly, we're developing in-language materials for like hurricane preparedness and COVID now. But then when I talk to some of the people at the Hope Clinic, I'm finding low levels of literacy. And even though they have those language materials, you still need the oral presentation of information in order to really get to those communities. And academic research and product development research support the highest quality and most innovative research, including clinical trials that will enhance the potential for medical and scientific breakthroughs in cancer and other diseases, and improve cancer care by accelerating the movement of prevention interventions. As a former researcher, it was often hard to get funding. I'm glad that like CPRIT and other organizations in Texas are starting to realize the importance of getting funding for underserved groups. Okay, I want to speed through because I want to get to some of these other things. As I was saying, when Fergian and Helen asked me to speak, they said, touch upon how COVID has impacted cancer, and yet I don't want to overshadow that. But some of the things that when I was looking at COVID and how it's impacted the AAPI community is it found that there is a COVID-19 registry, which already shows racial disparities and economic impact of the pandemic. More than 40% of Houston area households have lost income as a result of the pandemic, and the pandemic appears to be taking a greater economic toll on African American and Hispanic households than white and Asian American households. But this is based on survey data from Rice University, where they're collecting data through this thing called COVID-19 registry. Now, I haven't looked at it lately, but I don't really know. I asked them, do you have any Asian-specific data? And at that point in time, their Asian Pacific Islander subjects were quite small. Then this is data that's actually from the Texas Department of State Health Services. And this is COVID cases in Texas by race. And something else that Camille brought up is the importance of disaggregated data. So as we can see here is actually there's very few cases, and it's proportionate to the population in Texas as to how many COVID cases there are. And then COVID deaths in Texas, again, it's pretty much proportionate to the racial ethnic groups in Texas. Now this is Houston-Harris County, and this is racial ethnicity of COVID cases in Houston-Harris County. And we did have, this is our data from the 8th of July, because that was the last day I could pull data to get my PowerPoint together. We had documented at that point in time race 829 cases in Houston-Harris County. Let me see, I thought I put a slide in here about, oh, I know, this was the thing I want to say. Is on this slide, you notice what is the largest group is unknown. And this has been a big challenge for everybody everywhere. In the beginning of the COVID pandemic, people said, are you collecting data on race ethnicity? And they said, no, we're not. And so then they had to backtrack. So you can see that the largest cohort here is really cases that are unknown. So it's been a very harsh challenge to see about the impact of the pandemic on our community. Yeah. Okay. So cancer risk factors, just want to talk about, you all know that probably by now, is age, alcohol, and some of these, again, Camille talked about. We're trying to address those things. Local AAPI cancer control activities. You know, the Asian Cancer Council, which was housed at the American Cancer Society, was a very supportive and just really helped us kind of galvanize our efforts about cancer control. But they are going through some challenges now. Talked to Gloria Robinson, who's our contact person there, and she says, you know, Dr. Gor, really, we would love to support you again, but we kind of have to look at our own survivorship at this point in time. So I told her, I said, whatever the Asian community can do to support their efforts, really want to see what we can do to reciprocate for their efforts. Light and Salt has been very instrumental, continuing to do that. Asian American Health Coalition, Hope Clinic, and as mentioned before, UTMB Anderson is trying to provide culturally and linguistically appropriate services and outreach. So this was the Asian Cancer Council back a while back. Our dear friend, Dr. Bing Ho, is living in a nursing home now. He's doing well, but he's under isolation. So because of the COVID, and you know, we communicate a little bit by, you know, text and email, but he's doing okay. So a lot of our founders, I noticed that Sir John Min is on the call. Somebody else that was on the call, Chris Light and Salt is there. Okay. This was a paper that actually starting to get a little bit of traction that I got to co-author with some people about young Asian Americans' knowledge and perceptions of cervical cancer and the human papillomavirus. Actually, I've been seeing more sightings of this now because people are looking at the rates of HPV vaccination, and even though it's not, again, kind of on the back burner, this paper is kind of being looked at, and we are doing more. I can see more people looking at that in terms of other Asian communities, HPV and cervical cancer control. Now, one of the more recent studies that has been done, and I want to acknowledge Yin, who's on the call, is she was very vital in doing this Vietnamese nail salon workers project called Nail It. And we've talked a little bit about it before, but in it, we had 398 surveys collected, 381 nail salons visited, and 531 interviews in the South Houston, Chinatown, and Katy area that were conducted among Vietnamese nail salon workers. That's a phenomenal number. This project was supported by the Episcopal Health Foundation. But what they were trying to do was assess what are some of the barriers to cancer prevention, chronic health condition screenings among these nail salon workers. So this is some of the demographics. There were about 92% born in Vietnam, 92% reported wearing gloves, of which 68% experienced chemicals leaking through their gloves, chronic health conditions. They had a lack of health insurance and lack of access to health care. So one of the things that was done and was supported by CPRIT, and I don't know, okay, so this was 2016, and I think they might have done another one in 2018, is 2019 even, is the Papaloosa, where they brought in all of those nail salon workers and other women who had not had a chance to have cancer screenings and other screenings, pap smear, HPV, clinical breast exam, plus HPV and hepatitis C. They did a whole day of screenings, and it was phenomenal. I mean, really, people who had never been screened before were finally able to access services. And I know Dr. Kara Costas was very conscious, as well as Shane and the other staff, about making it a one-stop shop for these women, so that they have to come back if there were findings. They did the the screening on the if there was a problem found on the pap test, that they right away did some kind of treatment. So this was very innovative, I think, and something that we can learn and apply to other communities. This is kind of a composite of some things that have been done in the Indian American community. They've been doing some cancer education things, and also they've been doing cancer education workshops. And of course, we did the South Asian Health Needs Assessment Study in 2014, which provided some data about cancer risk for that community. And then most recently, we were told about a group called SALT, which is doing a community survey on COVID-19 in South Asian Americans, which we're trying to push to our community. Camille kind of talked about this, the importance of disaggregated data, that yes, if we look at Asian Americans as a whole, we don't see that it is a male-dominated, how do you say it, the health behavior to use tobacco, and especially with Southeast Asian men. So it's very important that we disaggregate the data for these communities. And this was what we found actually with the South Asian community, is that about 12% of the men and 0.6% of the women use tobacco. Okay. She pointed out something else that I thought was very important, and this is, I have to apologize. I have this great data that Appeal helped me collect, but we haven't been able to get it published, and that's one of my goals, is she's right. The initiation of tobacco in the youth is later in age. So when you do youth tobacco studies with Asian youth, you don't find the prevalence to be very high, because the initiation tends to be later on. And this is something from 2019 that I do want to thank Light and Salt for helping me with a lot, and Dr. Marjorie Kagawa-Singer and the UCLA group, is that we did some community town hall meetings, cancer support and survivorship in the Vietnamese community, cancer survivorship in the Chinese community, back in January of 2019, which provided the results of a study we did on cancer survivorship in Chinese Vietnamese women, for what the results of that, what were their barriers and so forth to this. And then finally, I wanted to talk a little bit about what was done about, diet and nutrition. We did do a couple of workshops. The Asian American Health Coalition banded with Sodexo to do some, one workshop in Vietnamese and one in Chinese that I thought went really very well. Hopefully that can continue. Sodexo is kind of changing their format now too, so I don't know if we'll be able to do more of those, but they're interested. And then we did promote this Pacific Islanders COVID-19 National Town Hall, which several people in our community got to listen in on. And we realized that we don't have a large Pacific Islander community here in Texas, but we're realizing that many of them, we're going to be doing, this is a regional AAPI Health Summit in October 29th and 30th. And we wanted to definitely include the Pacific Islander community, particularly the speaker from Arkansas, Dr. Sheldon Ricklon, who will talk about the disproportionate burden of disease in that community. So to summarize, cancer control and prevention for AA-NHPIs in Texas, we do need to continue to collect data, disaggregate it if possible. We need to interpret the data in light of cultural perspectives. We need to design interventions that would be meaningful and relevant to the community, involve and empower members of the impacted community, evaluate programs for effectiveness, share results with funders, researchers, and the community, and adapt them to other Asian and Pacific Islander groups. Thank you.
Yeah, so that's national, I believe, and they actually have, I can get you the data from Asian Smokers Quit Line actually, because they have data from each state of how many callers there are.
Very good.
So I can definitely get that to you if you want.
Okay,
and
and
I can
then
get your email.
I wanted to ask you too, do we have any data on how AA-NHPI populations quit tobacco? Because, you know, Fergen and I have had informal conversations about use of nicotine patches and so forth, but then there's a lot of anecdotal data that a lot of them quit cold turkey. I don't know.
Yeah, I'm not sure specifically like the rate of successful quit attempts, but I do know that Asians and Pacific Islanders have a really high rates of interest in quitting. I think it's like 60%. Like it's really high. I can also ask Asian Smokers Quit Line if they have that data as well. I believe I have your email through the thread, so I will circle back with you and connect you with Cherry, who is the coordinator for Asian Smokers Quit Line. Okay.
And then the final question, hopefully, Camille, do we have any data on vaping among our API communities?
Yes, I'll get that to you. I do have some vaping data nationally. The one I talked about in my presentation, I have that as well. I have the 2017 one, which is the latest one I have. And then there's also one that is specifically from Hawaii, just the state of Hawaii for HPIs. But yeah, I'll make a list of what to send you.
Thank you.
You know, it's interesting you talk about vaping. My godson is African American, and he and I have had talks about smoking ever since he was a little kid, and he would never smoke. But he and his mom actually recently started going to hookah lounges, and they don't see that as smoking, and it just drives me crazy.
Oh no!
I wonder, what is the prevalence of people going to these hookah lounges now? It seems to be very popular. San Diego has a lot of these lounges.
Yeah, it's crazy. We've seen like hookah's the popular spot now, and we don't know too much yet about hookah. But yeah, that's definitely something we're looking more into, is to how to address hookah as tobacco use, because you're right, it's seen as like a social thing, and like not enough is known about it. So yeah, it's very, I'm sorry to hear that. Now they're going to hookah lounges. Oh my goodness.
I read one.
With your mom too.
I know. I read one article that, research article that said that you actually get a lot more nicotine when you do that, because you know, I don't do it, so I'm not exactly sure how it works, but I know it's through water or I don't know.
Yeah.
But I guess it's the flavors they like, which, you know, it's just like how they target little kids. But the reason why he told me why they liked it so much is because they like the flavors. And it just drove me crazy. He's been talking about tobacco. He just doesn't see it.
And it's definitely, there's also, some of you may know, flavors that particularly entices NHPIs, like taro, for example, tropical flavors, mango, right? It's like, come on, who are you really targeting? Like, we know you're, and we did this Twitter chat all about e-cigarettes last year. And, you know, some tobacco trolls joined, like they were just joining conversation, like whatever we post, they had something to say. And then when I posted, oh, actually, Native Hawaiians and Pacific Islander kids have the highest rates of e-cigarettes, they were like dead silent. Like, we don't have anything to say about that. I mean, you can just tell that they're really targeting kids with all these flavors. Like, why are you, what kind of adult would smoke bubblegum flavor? Like, It's just all these flavors are really just for kids, for youth.
I'm wondering if anybody else on the Zoom thing here has any anecdotal stories or any other data about, you know, vaping or these hookah lounges or COVID-19 in your communities. In California, I was telling somebody before the call, in California, in Southern California, Native Hawaiian and Pacific Islanders, we have a pretty large population of Pacific Islanders, mostly Chamorro in San Diego County, but Native Hawaiian Pacific Islanders are by far the tiniest community, although I think American Indians are a little bit tinier, but they have the largest rate of COVID in San Diego County. In California, Northern California, Asians have a pretty small rate of COVID-19, but if, this is being studied at UCSF, if you're an Asian and you get COVID-19, you have a higher chance of dying from it. So they're trying to study that at UCSF right now. They don't know why that is, and it doesn't necessarily have to do with pre-existing conditions or any of the things that we normally think of. Does anybody else have some data about that or any information from your communities about either tobacco or COVID or vaping? Wilson, go ahead and turn off or turn on, what do you call that? Unmute yourself and tell us what you have to share.
Oh, so I was just saying that I'm doing research on menthol cigarettes in Hawaii, and yeah, Native Hawaiians do have the highest rate, prevalence or proportion.
Do you know why that is?
Well, for several reasons. Well, their socioeconomic status. Native Hawaiians tend to have lower socioeconomic status. There's also racism. Tobacco companies target certain races, and according to marketing documentations, they said that Hawaii is like a menthol market.
Oh my God.
Yeah, I'll share more about it when I
do
my presentation.
Okay, that's good.
Wow.
I've actually been working with tobacco related stuff ever since undergrad.
Good.
So, yeah.
Great.
You know, I have to say, and I hate to be devil's advocate, you know, tobacco is still a what do you call it, free enterprise, and they're going to market what they're going to market, and they're out for the bottom line. But I think, you know, the tact we need to take is, like you said, educating our community that you're being targeted and you're kind of being played, you know, and I think if we can arm them with that information, they're better consumers, and maybe hopefully we'll make better choices. Yeah, I don't know. That's just my thoughts.
Are young people, Camille or Beverly or Wilson, are young people starting smoking earlier? I mean, is that, because I know for a while it wasn't such a big thing for young kids, but in our community.
For cigarettes, smokers, I know that for menthol cigarettes, we have high proportion of menthol cigarettes among the youth. If you go to like stores, you'll see that there's like advertisement of like menthol cigarettes like on top of right in front of like the ice cream, or like
oh my God,
you know, eye level of the, you know, for the kids, like bag of chips, you know. So when they see a bag of chips or like ice cream, they also see menthol cigarettes.
What about e-cigarettes?
E-cigarettes, I don't know too much about e-cigarettes. I mean, they do market like all these different candy flavors that attract kids. So yeah.
Mm-hmm. Yeah, definitely the placement of their products is one of their key factors of like why it attracts kids. It's like eye level and big bright posters. But yeah, I think I don't know the specific, but it's like for youth who do end up being cigarette smokers, a lot of them start out with e-cigarettes. That's how they get hooked. Menthol, they get hooked easily on menthol because of the flavor. It's very light, so it's like it's not like a harsh tobacco flavor that you're automatically like that you're inhaling, but you know, it's like a really minty, keeps your breath fresh. Really, I think so. I don't know. I've never really smoked menthol or smoked, but yeah, that's part of the reason why menthol is very popular, particularly for African American communities.
Yes.
They have a really high prevalence of menthol, but as well as Asians, Asian populations. My gosh, I can remember. So I was born in the Philippines. I would buy menthol cigarettes for my uncles when I was like 5. You know, I could like easily smoke that at 5 years old, but I knew better, I guess, at 5 years old. But yeah, menthol, it gets you hooked. That's why there's a lot of policy or ordinances or policies right now that are that we want to advocate for, that includes a menthol as a flavor, because I don't think I think in some states they don't count menthol as flavor, which I don't know why. So in a lot of the policies that we advocate for, we definitely try to include menthol in that instead of just the other flavors. Yeah.
What about some of the other communities, South Asian communities?
I just want to say that in 2009, the FDA banned all flavored cigarettes except menthol. The tobacco industry fight really hard to keep menthol because menthol it suppresses respiratory irritants. So like you have this cooling of feeling when you smoke. You don't feel all that harsh chemicals, so you can breathe in more, take in more nicotine, so you become more addicted. It's easier. So basically, menthol makes it easier to start and harder to quit.
So what was the wisdom behind not banning menthol?
Yeah.
Well, to be honest, I don't know. I believe that menthol is a flavor, but you know, the tobacco industry fight really, really hard to keep menthol. And by the way, if you look at the Black community, about 93% of those who smoke begin with menthol cigarettes.
Right.
That's terrible, which is really sad because it used to be back like 20 years ago, it used to be that African-American youth had the lowest smoking rates. And I guess with the menthol, it's going up.
Yeah. I just go ahead. Sorry. Go ahead.
Is there any data saying that if they start smoking younger age, then it's
I'll look
difficult
for
to
that data.
quitting?
Yeah, I'll look for that data. I'm taking all my notes here of all the data I need to send. But yeah, I'll take a look at that. Ahmad. And who said, was that? Who asked for that data? Sorry, there's a lot of.
No, I was asking that is there any data that if the younger age they start smoking the younger age, then it's more difficult to quit the smoking.
Yeah, there's data on how what the prevalence of Asian youth smokers in general. I can find that, but I'm not sure if there's data of like reasons why they start smoking earlier. But I do have a data of the percentage in general of how Asian American youth who smoke.
Is that disaggregated?
I think it's part of the e-cigarette data that I'm going to send Beverly. They actually desegregated traditional cigarette, e-cigarettes, and other types of tobacco. So,
but are the communities disaggregated? Like
not by subpopulation, no. It's just it's very hard to find that subpopulation data. It's at least they desegregated Asian from Native Hawaiians and Pacific Islanders, but in terms of subpopulation, yeah, unfortunately, it's so hard to find those data. And then I just quickly, I wanted to go back on the menthol. I sent a link on, oh shoot, I think I just sent it to Ellen. Never mind. I'm gonna send it to everyone right now.
Everyone now.
Oh, okay. Oh, there you go. Thank you. So back to menthol. The African American National Network, which is the counterpart of Aspire, they cater to African Americans. They do this event called No Menthol Sundays every May. And it's just a movement that they started that just addresses menthol use in African American communities. So you can find out more about it through that website I sent on the chat box.
Thank you.
You
Anybody
know,
else?
just a quick question. I was thinking, has the pandemic increased cigarette sales because people are trying to cope with stress? Anybody hear about that?
That's a good question.
I'm sure yeah, good question. I think for some communities, there have been. There's a very small, one of the groups we work with at Appeal in Orange County, LA area, they did a survey on COVID-19 and COVID-19 and tobacco use within the Pacific Islander community, Native Hawaiians and Pacific Islander. And again, it's a very small data. And they found that, yes, they have been smoking more because of stress, unemployment, and just, really high stress is their main reason why they're smoking more. And the stress of not being able to work and, not finding where your money is coming from. So that was like what they found was the main reason why people that they surveyed were smoking more. The survey isn't out yet. I think it's still being finalized, but I'm sure when the reporting is, when it's all finished, Appeal will release it. It's part of, I work as a program manager for our program called Aspire, and that survey is part of another program that we do at Appeal. So I don't know too much about it, but I'm sure Appeal will release that once it's ready.
Okay, well, thank you. Does anybody else have any more comments or questions?
I have questions about,
Yeah.
it's not related to tobacco, but since last time is many state approval for the marijuana to legalize. So there is a lot of complication from marijuana, but they never come up to our society. Anybody, any study, nothing come out. Have you thought about it? Anybody?
So, Sergio, you're asking about does the legalization of marijuana?
Yeah, that's why a lot of people's children and adults legally they smoking marijuana, but never they have a more complication from the marijuana. It's a brain damage and all that. But there is no study on that marijuana smoker. So I have just recently I had a lot of people had some complication from that. So I just wanna, anybody has heard it or anybody had research done? Nothing. Have you heard it?
I haven't heard of brain damage associated with marijuana smoking.
But how about the, they have more toxicity than cigarette, I think. But they are
I was going to say, isn't one of the applications for pain control and cancer control and cancer pain control to use?
Yeah, they
Also
started with the nausea control and
Yeah.
pain. Yeah, that's what legalized in medically. But now it's many state approval
That's legal
regular people to
everywhere.
smoke.
Yeah.
But that's going
We
to
don't
be a
do-
big
yeah.
problem later on.
Yeah, we don't at Appeal, we don't do too much marijuana work, but I think what I've heard is that compared to tobacco, the marijuana issue is still very much new. Tobacco, it took decades for us to figure out, like, oh my gosh, it causes lung cancer, what? But with marijuana, I think right now a lot of studies are still being done. That's why we don't have concrete evidence of the long-term effects of marijuana. That's what I've heard.
I think we
know if
should
anyone else
start
has
with
any-
the Asian community, especially children, like the high school children
They're not
need
supposed
to,
to be able to get it legally.
yeah, get data. We need to get some data for that. We have a think about it long-term, complication from that. So, and also marijuana started, then they go to the really strong medication, the prescriptive pain medication. That is the biggest problem in the United States for the children. So far, I know many Asian youth groups has a lot of problem, even though they go to church regularly, but and after peer groups in the school give it all the problem. So they start with the marijuana, then go more higher. So it's eventually they got really hooked on narcotic for that. Addictive behavior is really problem, but I don't know. I haven't heard anything about Asian youth group for that research. What do you think? It's not related. I'm sorry.
No, that's okay. If anybody has any information or any research or leads, please share it with us. Okay. All right. Well, I'm going to move on. I want to thank both Beverly and Camille for their presentations. And